All right, good afternoon. This is the fourth attempt now to record this lecture. I've successfully recorded it twice without sound, and then once without the PowerPoint somehow, and then once separately. So I three times. So I don't know what I do with this, but it's going to be a short lecture. This lecture is designed to be during your week of practicals, which you just had. So I hope you all did well. Let's just talk about a quick kind of medical application of physics. We're going to talk about imaging and stuff like that. And then I'm going to let you go and you guys are going to have a happy holiday. So let's get right into it. All right. So we're going to talk today about some medical applications of physics. Specifically, a lot of this lesson is going to be dealing with imaging studies. So like X-rays, MRIs, and stuff like that. So we're going to talk about X-rays, we're going to talk about CTs, PET scans, MRIs, optical imaging, and then some ultrasound. We'll touch briefly again on E-stim and low-level laser therapy as well. Don't get too stuck in those because those are going to be the majority of next semester's topics. So let's start talking mainly, first of all, about imaging, right? One of the most important uses of physics in the medical field is medical imaging, and in physical therapy as well. Right. As a PTA, please understand, we are not required to read or interpret medical imaging. And actually, if a patient asks us to read or interpret medical imaging, even if you have training on it, we are not to do that. Like if we see an image, we're like, oh, that's a clear fracture. We are not allowed to say that the patient has a fracture. They should always be referred back to their physician, or if they're in the hospital, to the nursing staff until they get the radiologist report. We should not educate them on pretty much anything in that X-ray unless it's already kind of findings. The findings are there and the patient says, hey, the radiologist said I have a fracture here. What does that mean? Well, you can show them where the fracture is. You can't explain much about it. You can't tell them the difference between a spiral fracture and a compound fracture or something like that. But you can explain, hey, you have a fracture in the humerus, right? For us, we have to know that if the radiologist says fractures in the humerus, that we're looking in the arm, not in the leg. That's our main job. We also have to understand the difference between things like compression fractures and spiral fractures and stuff like that, which we will cover in pathology next semester. But all imaging comes back to some basic form of wavelength in some shape or form in physics. It really does. First, obviously, one of the most common we talk about is X-rays, right? And if we talked about that EM spectrum before, X-rays are above that ultraviolet portion. Because they have that high energy constant, they can pass through the body easily, including most objects, actually, right? We can use X-rays to, like, for example, the bomb squads. The bomb squads use X-rays a lot to look inside objects so they can see if there's a bomb in there. When you go through the machines at McCarran, right? Especially that one where you stand with your hands high, that's just a rotating X-ray machine. That's all it is. Not the metal detector that most of us walk through. As that X-ray passes through the patient, it will strike a detector on the back of the patient and leave an image or a shadow of the patient. Back to that topic of McCarran, right? For me, because I've got plates on my neck, if I go through the metal detector, guess what happens? The metal detector goes off. So I have to go through the scan machine. And that basically gives them kind of an overview of, oh yeah, look, he's got metal in his neck. That's why the metal detectors are going off. So the films from X-rays are called radiographs. That doesn't matter whether it's the old school kind of plate style radiographs or the newer school electronic radiographs. They're called radiographs. Those X-rays will travel through the human body and be absorbed at different amounts by different types of tissue. So because bones have a high calcium concentration and readily absorb X-rays, they produce the best radiographic picture and are easily appear white on the black background of the X-ray. Therefore, harder composite tissues will be better detected with this form of imaging. It can be also used to detect bone malalignment or fractures. There's also a form called radiation treatment we use in the treatment of cancer. We're not going to specifically get into that, but they use focused X-ray beams to target and destroy very specific forms of cancer, right? X-rays themselves are not specific nor sensitive to detect soft tissue injury, meaning if you have an ACL tear, an X-ray is really not going to tell us much. Now, if you have an ACL tear with subsequent anterior translocation of the tibia, the X-ray can detect the translocation of the tibia, the movement of the tibia, but it can't tell us that the ACL is torn, right? It is usually only for hard tissue. So then we get into CTs, right? CTs is a more narrowly designed form of an X-ray, and it's used to generate cross-sectional imagings of the human body. It's a narrow, powerful X-ray beam is fired and then quickly rotated around the body, and it produces the CT imager produces this 3D60 view of the body, or 360 view of the body. Those images can then be stacked and can be used to create a full image of the body or the cavity that we're looking at. They can be used they're really useful at finding things like tumors and lesions, frequently in the heart, when heart disease is suspected. Can also be used in the head to locate injuries such as clots, hemorrhages, stuff like that. Oftentimes, imaging contrast agent will be included with the CT in order to cause a reaction, right? Iodine is typically one of the ones that are used because it helps illuminate the blood vessels. The iodine is reactive to that focus beam. So when that focus beam hits it, they light up like a Christmas tree, right? The CT scans are often used when more fine detailed imaging is needed than an X-ray and more of a diagnostic criteria is required. We're gonna find out in a little bit here. Most doctors will tell you that you just don't order a CT scan on a whim because the cost to the consumer is great, as well as the radiation exposure. And we'll talk about that in a bit. PET scans, positron emission tomography, right? It's used in creating 3D imaging of the body by creating radioactive tracer contrast, which is injected into the body's bloodstream. So very similar to the contrast that they use in CT scans. In this case, they're using a radioactive tracer, which goes into the bloodstream. That tracer has carrier molecules, and they're tightly bonded together, and they're isotopically designed to bind with specific tissues of the body. So there are specific ones they inject that bind with cancer cells. There are specific ones that they inject that bind with, I'm drawing a blank right now, brain cells, stuff like that. So that means the carrier molecule will be closely chosen by the imaging radiographer based upon the orders that they're stated to look for, right? So they're not going to use the cancer cell isotope on somebody that they're going into their brain unless they're looking for brain cancer. The good news is the radioactive tracers themselves pose very little danger to the patient. Now, the waves going in, a little different story, but the tracers themselves you pass pretty quickly. So not a lot of worry there. The tracer reacts with localized electron in the tissue targeted. They bounce off each other and they send off photons. And those photons we know don't carry a lot of baggage because they're traveling light. Okay, right? The PET scanner itself around the patient will detect those photons being emitted, hence positron emission technology, right? And it'll determine a full 3D image of the area being scanned. So if we're doing a positron of the kidney, when they inject that tracer goes in and reacts with that area around the kidney and sends off light beams. Those light beams are invisible, but can be detected by the scanner itself. And we get a 3D image of just the kidney. It's really impressive. MRI, probably the one you're going to hear most about nowadays. MRI stands for magnetic resonance imaging. This is non-invasive technology that can produce 3D images, much like the CT scan, right? And fully anatomical models of patients. It's almost like sonar, if you're familiar with sonar for like chips and stuff like that, right? It's very like sonar for the human body. But unlike traditional imaging, MRIs use magnets instead of specifically radioactive waves to create a magnetic field around the patient, causes the protons in the human body to align with that field and produces an image, right? The downside to that is the patient must be placed in a large magnet, often a tight, tiny tube, and must remain perfectly still through the procedure. Any movement can flaw the image. So even if you just wiggle your nose, that can actually flaw the image elsewhere in the body. So you have to remain perfectly still. And again, most of the MRIs have these really, really tight, tiny tubes, and the MRI is loud. It is a loud boom, 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 as it produces that magnetic field around you. On a positive note, again, there's no radioactive waves with this. On the negative note, most people don't like being shoved in a tiny tube, right? The form of radiation damage are really low. Most studies say it's completely undetectable. And MRIs can be used for most traditional X-ray uses and CT uses, but the downside is the price. The cost of MRIs are really expensive, and the psychosomatic effects. People don't like being shoved in a tube. It just doesn't like. Most people say, "Oh, I'm not claustrophobic," until they get an MRI, and then suddenly they become claustrophobic, right? And people just don't like to lie still. I'm sitting here right now bouncing because that's just kind of my way. Another plus here is MRIs can be highly tuned to determine soft tissue injuries. So they can find ACL tears, tears in the supraspinatus tendon, stuff like that, whereas X-rays can't detect that. There's also this very specific type of an MRI called a functional MRI that can be used to observe brain structures and determine what structures activate during functional cognitive activities. So we can have an MRI going while a patient's doing stuff like a puzzle, and we can actually see what areas of the brain are lighting up while the patient's doing it. Or we can flash images in front of them and see if the visual cortex lights up, or we can play music, see if the auditory cortex lights up. Interesting story to that, they actually did a study with patients that are blind. And you would think that a patient that's blind, their visual cortex never lights up. But what they found is a patient that's blind, when they hear sounds, part of their visual cortex lights up. And there's some theory behind that, there's some latent pathways, there's some neuroplasticity that the brain uses some of that visual cortex that's not being used for processing sound. The other thing is excuse me, maybe the brain itself creates an image for the patient based upon the sound they hear, which is, I mean, we'll talk about echolocation in, I think, rehab too. But it's just kind of an interesting subject that, hey, look, we're able to determine what part of the brain lights up when we do things. So with X-rays, because there's X-rays and all the other stuff, with all of those, there's a chance of radiation because it's being sent through your body, right? So it's an extremity X-ray, say an arm or a leg. It's comparable to about 3 hours of normal background outside radiation. So it's about the same as spending about 3 hours outside. It's about 1 in 2,000 risk of developing cancer. To put that in perspective, a cross-country flight, so say you go from here to New York, is about a 1 in 200 chance risk of developing cancer because the plane itself doesn't protect you from as many of the outside radiation as it does in the ground. They say that a flight across country is much like a chest X-ray. Chest X-ray says is comparable to 10 days of normal background radiation, right? Spine X-ray, 6 months. CT, 6 months to several years, depending upon how long you're in the CT for. A PET scan, 8 years of normal background radiation. And not from, again, not from the dye itself, but from the scan itself. And a fluoroscopy, such as the kidneys, is comparable to 5 years of normal background radiation. So as you see, the higher you go up on the imaging scale, the greater the chance you have of developing cancer because those risks get higher. Does that mean if you go get 5 PET scans, you're going to get cancer? No, it may not. But that may mean that one person goes and gets a PET scan and develops cancer from it because of the radiation, right? So there's a risk there. There's also a risk for those people that perform these tests, right? If you're an X-ray tech or you're a radiologist, a lot of times they have a little badge they wear, and that badge has a detector on it. Once that detector reaches a certain point, they've got to step out and not be in the X-ray room for quite some time until things calm down. And you can only work in this field for so long before you've got problems, right? That's why lead vest and all the other protective equipment are important, right? It's why you don't want to be in the room when somebody's getting a PET scan. It's why they don't allow you to go with family members like, oh, I'll go with Johnny to the PET scan. No, you can't do that because that puts you at risk as well. So ultrasound we touched briefly on in physical therapy world, and will be covered much more in depth next semester. But understand, ultrasound primarily falls in 2 categories, diagnostic and therapeutic. We're the therapeutic version. We're going to talk a little bit about the diagnostic version today, right? Much like the ultrasound we use in physical therapy, diagnostic ultrasound uses a transducer, which is the wand in the head, right? A coupling agent, usually ultrasound gel, to send radio waves or sound waves into the human body, often above 20 kilohertz, right? And remember, when we talked about ultrasound for therapeutic uses, we're talking about megahertz, right? So usually that tells you how high these are going to have to be to bounce off structures in the human body, and they bounce back. Remember, the lower the frequency, the deeper it penetrates. So if we use a little bit lower frequency ultrasound in imaging, we can get a better image back. Those reflected waves are detected by the transducer and can produce either an image in the case of something like a pregnancy ultrasound, or a sound in the case of a pulse Doppler for arteries and veins. And we'll show you that next semester with anatomy. We have a pulse Doppler in the actual anatomy lab. So on top of those, there's also optical imaging, right? So optical imaging uses light and special properties of photons to obtain detailed images of organs, tissues, and cells. There we go, I can speak. Even down to the molecular level. So understand this is a newer technology. It offers minimally or non-invasive methods for looking inside the body. Significantly reduces the patient exposure to harmful radiation by using non-ionizing radiation, meaning it doesn't react with the body. Because it's safer than techniques that require ionizing radiation like X-rays, optical imaging can be used for repeated procedures to monitor progression of a disease. So, if you imagine you have a disease that you have to monitor via PET scan and you're constantly getting PET scans, well, sooner or later, you're going to roll the dice into cancer. So optical imaging may be the way to go. Now, again, optical imaging is particularly used for measuring multiple properties of soft tissue, but it is more expensive. That's why it's not used as frequently. All right, so we're going to talk about a couple of different types here. Please note the first thing it says here, don't study these. We're not going to have questions on specifics about endoscopy versus OCT. This is just kind of an FYI so that you kind of understand when if you hear somebody going for these, you understand what it means. Endoscope, all of us will probably have to go for this eventually, right? Either down or up. It inserts a flexible tube with a light source to illuminate organs or tissues. An endoscope can be inserted through a patient's mouth or in the digestive cavity or through other ways to diagnose symptoms like pain, difficulty swallowing, GI bleeding, tumors in the lower intestine, stuff like that. OCT, or optical coherence tomography, is a technique for obtaining subsurface images such as diseased tissues just below the skin. This can be used in the cases like ophthalmologists to look at the retina. Cardiologists also use to diagnose coronary artery disease, can be used to detect skin cancer as well. So there are a couple different uses for that. There's photoacoustic imaging. It delivers a laser pulse to the patient's tissue. The pulse generates heat by expanding the tissue and enabling the structure to be imaged. So that's another method here with optical imaging. DOT, or diffuse optical tomography, and imaging, or DOIA. Non-invasive techniques use light in the near infrared region, so we're moving to the other end of the spectrum, to detect things such as hemoglobin concentration and blood oxygen saturation. So that little pulse ox device, right, uses DOT technology to determine if you have the right level of oxygen in your blood. Also, something simple like your Apple Watch uses that to detect your heart rate and stuff like that. That little lights on the back is using that technique. Raman Spectroscopy uses Raman scattering of visible near light infrared or near ultraviolet light. It's again a laser technique that interacts with molecular vibrations of material, which reveals shifts in energy and reveals the material's chemical properties. Again, we're starting to get into some really specialized versions here, like specifically this one down bottom, super resolution microscopy, right? This actually allows us to look down at the cellular level or the molecular level. So again, not something you're gonna have to know, but at least it's interesting to see that we're starting to develop techniques now that keep us away from having to use ionizing radiation as much, which is a good thing. Don't get me wrong. Ionizing radiation we've used for years, but we understand now that it's not the best option. So what does that mean? Does that mean if you've got to go get imaging done, you should avoid getting x-rays if you can? I mean, yeah, sure, right? I mean, just think about it, keep track of how many x-rays you've had in your life, how many CT scans you've had in your life, right? I've had quite a few because of my head injuries, and you got to be careful with that. So ultrasound, I don't know how I somehow messed that up. I'll fix that in the version I upload. I guess I somehow moved a slide and didn't move far enough up. Back to ultrasound now. In the imaging form of ultrasound, the transducer generates an electrical signal based on the reflected waves and can produce 2D image. Everyone's seen somebody that's got an ultrasound from a baby. Like if you haven't had a friend that's been pregnant before, because they show those pictures like crazy, right? Just like therapeutic ultrasound, though, it requires consistent and constant coupling agent to maintain image quality and with contact to the human body, right? If you don't maintain contact, it doesn't produce an image. It's just like ultrasound that we do in therapy. If it doesn't maintain contact, we don't get a result out of it. Can obviously use to detect pregnancies, problems with internal organs, pockets of air where there shouldn't be pockets of air, and even problems in blood vessels, maybe if you have a clot or something like that, right? So we used oftentimes Doppler ultrasound on the calves to look for DVTs, deep vein thromboses. Again, because there's no ionizing radiation, there's no specific risk for cancer with ultrasound. So that's a good idea. Though there are some specific guidelines, and we'll talk about those next semester, of when ultrasound can be used and when it can't be used. E-stim is a topic we'll cover in depth next semester, but it works on same basic physical concepts. As previously discussed, E-stim can be focused for pain relief, muscle control and activation, wound care, and edema control. There's also a form of E-stim called biofeedback that can be used as diagnostic criteria to determine levels of muscle recruitment by a patient. So we have a couple of different forms of E-stim. But when it comes down to it, works on principles of interrupting the normal or abnormal electrical activity in the body to produce a result. So in the case of muscle control activation, E-stim will be used to trigger an action potential of the muscle, at which point are no longer either responding to the brain's own electrical signals or responding poorly to them. So if you have somebody that's not getting a good muscle contraction from the bicep, we can use E-stim on that to interrupt the problem and cause the contraction to happen. By far, when we get an E-stim next semester, this will be the least favorite E-stim of everybody that's out there. Most people don't like their muscles being forced to contract. It doesn't feel good, right? And we'll even talk about it. I often tell my patients, this is going to be an uncomfortable sensation. Or I tell them it's not going to feel great, because it doesn't. E-stim that causes a body contraction just doesn't feel normal, right? But we have to be upfront, kind of upfront with our patients. If I'm working with a child and I have to do E-stim on them to trigger a muscle contraction, it usually hurts. Doesn't feel good. And the kid doesn't like it. In the case of pain relief, E-stim usually works on two basic principles, either the gait control theory or the endogenous opiate. Now, this is really oversimplifying it. So please don't think this is everything you need to know here, but this will hopefully for next semester get you set up so that when you talk about this, it goes, oh, now I understand. This makes sense now, right? So the gait control theory is basically closing a pain gate for a patient. So that's why it's called gait control. It works on the theory that the brain can only receive so many signals. And if we can block the pain signal, well, then maybe we can keep the patient from being in pain. Easy example of this, right? You smack your head on a door frame, maybe because you're too tall or maybe because the door is too short. Or you open a cabinet and like I've done a couple of times where you open it into my face for whatever reason. Your first response after curse words are said is usually to rub the area. Oh, God, that hurt, right? Or maybe you're playing baseball and get beamed with a pitch. And you're like, oh, man. And your first response is kind of rub it. That rubbing produces a different signal, which gates off the pain signal and overall reduces the transmission to the brain. That is gait control in its most simple form, right? And we can use, there's a couple different forms of gait control we can use, and we'll talk about that next semester, but that's the overall basics of gait control. Endogenous opiate release, right? This theory is basically, we cause pain to relieve pain, right? It works on the same principle. If your head hurts, close your hand in a door and forget about your head, right? My dad did this. I had a kind of fun upbringing, right? My dad did this once. I'll never forget it. We were out shooting, and one of the golden rules of shooting is make sure that you have the gun stock butt up against your shoulder so that you don't do something, so that the gun doesn't recoil very much. Well, man, that gun came back and smacked me in the face, and good Lord, did that hurt. So he stomped on my foot. And my dad was a big man, like 415 pounds at that point. And when he stomped on my foot, that hurt. And he looks at me and goes, bet your face doesn't hurt anymore. Well, in reality, what he was working on was the endogenous opiate release, right? It has a little bit to go with the gait control, but more what it does is it's a little more complex than that, right? The theory is if we create additional discomfort, you cause the body to release endogenous or inside of itself opiates, nociceptor shutdown chemicals, nociceptor are the pain receptors, to help create analgesia or pain relief, right? Now, let's say you're taking something, you've heard of opiates before, and you're like, oh God, opiates, Mr. McKeever, we can't have opiates. These are endogenous opiates, right? These are meaning inside your own body. These are naturally occurring, right? These are endorphins. Endorphins make you happy. Happy people don't kill people. We've learned that from the movies, right? These are normal endogenous opiates. Now, opiates that we take over the counter work on a similar theory, right? They block the pain signals. When you take Tylenol, which is an analgesic, a pain reliever, it doesn't stop your pain. Like right now, I've got a headache. I'm going to go take some Tylenol after this. The Tylenol doesn't stop whatever's causing my headache, right? Probably my headache right now is freaked out because I'm stressed out about this stupid lecture because it took me so many times to get it right. But what it'll do is it'll shut down the signals a little bit and tamp them down so that you can be functional, right? A lot of our pain meds work the same way. They don't stop the pain, right? If you have a broken femur and they give you a shot of morphine, that morphine doesn't stop the femur from being broken. That femur's still broken. It's still got pain there, but it just has shut off the body's response to that pain. So that's kind of the way this endogenous opiate release, right, will cause a little bit of pain or a little bit of uncomfortability in order, or discomfort, I guess would be a better term, in order to release pain relievers that help release pain. So those are the two main pain control theories. Now, there are a couple other different techniques as well, but if you understand those two, you understand most of Easton pain relief. So gait control, rubbing your head, right? Endogenous opioid. Oh my God, my left hand hurts, so I'm going to smack my right hand. You got it. Case of wound care. Well, this is a topic I could go into for quite some time. But in reality, with wound care and E-stim, the goal is to drive off the bad stuff, like infection, and bring in the good stuff, like nutrients, to lay down new matrices for the wound to heal. This will go into depth a little bit next semester, like un petit peu, very small amount. But we will hit it harder in wound care in 5th semester. So we're not gonna go deep into that. It's just, there's so much we can go into there. And in the case of edema control, we're talking about, again, edema means swelling. What we're going to use is a theory of likes repel and positives attract from normal electrical input. Excuse me. We're going to use an electrode with a similar polarity to push the edema, right? So likes repel. We're going to push the edema farther up in the human body, usually close to the lymphatic ducts. We'll put an opposite polarity electrode, and that'll be pulling the edema to the ducts. And the goal is to maybe move all the swelling out of the hand up into the armpit where the ducts are to get drained back in so that it gets passed out of the body. Again, it's just working on similar of likes repels, or likes repel, and opposites. That should be opposites attract. I got to fix that. Thank you for see. Look at this. Even on the 3rd time, I'm still catching things I've got to fix because I just speak and don't read. So likes repel and opposites attract, right? Laser, pew pew. I always wonder what we're going to do with the sharks when we work with lasers, right? Sharks with freaking laser beams. The acronym LASER stands for light or photon amplification by stimulated emission of radiation. So laser is radiation, right? In physical therapy, most of the time we're going to deal with low-level laser therapy or low light laser therapy, meaning there's not a lot of light to it. The instrument itself is considered a therapeutic laser or a laser probe. It's been historically classified as a non-thermal modality, meaning it doesn't produce heats, right? So non-thermal modalities are those physical agents that do not raise subcutaneous tissue temperature greater than 36 degrees Celsius or warmer than body temperature, right? So that means that laser itself is not responsible for a heating response, but a photochemical response. So when the photons enter the cell, certain molecules called chromophores react to it, trigger a photochemical reaction, leads to a desirable physiological effect. A lot of what we're going to talk about next semester, one of your big phrases you'll say is, it's working at the cellular level, because sometimes patients just don't feel it. And we need to understand that it's still working even if they don't feel it. Lasers is another form of energy that can be used to create a physiological change in tissue. They're usually divided into categories based on their medium. We can have solid state, crystal or glass lasers. Gas lasers are usually the most common, the ones you're going to see in physical therapy. There are semiconductor lasers, there are dye lasers, and then there are chemical-based lasers. So all of those exist out there, but most of the time we're going to deal with gas-type lasers, usually gallium nitride lasers in the physical therapy world. You don't have to know that. Please don't write that down as a study habit, but gallium nitride is usually the one we'll deal with. Can be used for various therapeutic effects in the human body, like tissue healing, analgesia, and it's thought to work by following techniques. That beam of light strikes the skin, creates a reaction. The photons get absorbed by chromophores. You get photobiomodulation because of the light. You get photobiostimulation, meaning that you trigger up those mitochondria to go. And then there will be some pain modulation by the endogenous opiate effect, meaning that you're causing a little bit of discomfort in the cells, which releases an opiate, which relieves pain. Multiple indications for low-level laser therapy. You can use it for wound care, pain reduction, increasing the tensile strength of a scar, decreasing scar tissue length, increasing inflammation. We can do that too if it's an acute phase. Bone healing. Had some really great results with carpal tunnel syndrome. Increased circulation, musculoskeletal relaxation, spasm relief, arthritic pain relief, trigger points, diabetic and alcoholic neuropathy. And again, this list is not all inclusive because the studies are still out about this, but there are multiple uses for the laser therapy out there. So again, if you look at this, when you look, that's the lecture in itself. It's only about 30 slides. Again, short lecture because of the fact that you had your big anatomy practical. But you can see that all the stuff we've learned about in physics throughout this semester has come back to haunt us. We use physics a lot. If there are any questions, please reach out to me. I hope you guys have a happy holidays. I won't say Merry Christmas because I don't want to assume everyone celebrates Christmas, but I hope you all have a happy holidays. I will still be available during the whole time, during the whole 2 weeks off, during those breaks. So if anyone needs anything, I'll still be available like tonight, Tuesday nights. And I'll also be available Friday afternoons. So please, if you need anything, please reach out to me. If not, I will see you in 2021. It's been great having you guys so far, and I can't wait to see where you guys go from here. Y'all have a good day and have a happy holidays.